here have something to work. So I make conclusions, like have a excellence in hysterectomy by 3 notes, and they can have a reduced hand, also have a low complications, and not just a
endoscopic hysterectomy step by step.
So far, and so forth.
As you can see,
next year we will have a very congress in Indonesia.
wave sign, and then you perform the hysterectomy reversely. So now we will talk about the skeletonizing the cervix. So basically what we perform is we just perform anterior colpotomy, and then we perform posterior colpotomy. Then afterwards we're skeletonizing the cervix, and it's that. But there are some tips how to do it properly. So what you find, your first cut must be in the junction between the vaginal rugate and the smooth epithelium. Why? If you do this, you will preserve the length of the vagina itself. And then we will find, we go inside more, and then we go to the supravaginal rectum, and then we go into the vesical uterine space and the anterior peritoneum. See, as you can see, it will preserve the vaginal line, so you must cut around a bit around here between the smooth and the rugate, and then it will help you to avoid unintentionally injury to the bladder, especially if you are looking, you're having a case with a previous C-section. It will be better for this. And then incision is closer to the point of the entry to the posterior and anterior peritoneum. So you do it on the anterior side and you do it on the posterior side. So the supravaginal septum is the fusion between the tissue that support the bladder, the upper vagina, and the cervix. There, you should go there. There's another tips that I took from Professor Lie and Professor Su, is to avoid the bladder pillar. So as you can see, you just need to put one cut, and then afterwards what you do is to dissect. In here, I try to avoid the bladder pillar that in the 1 o'clock and 11 o'clock position. If you cut that through from the very beginning, it will be bleeding for you. And then, if you are beginners in phenols, it will jeopardize your learning curve how to perform phenols in the future. So as you can see, I just cut, and then I do dissection, and I push a bit. See, there will be no blood at all. But if you cut the 11 or the 1 o'clock position, you will cut the bladder pillar, and there will be blood. You just ask my fellow here, Dr. Yanti. She has some bad experience of doing it like that. As you can see, there is still no bleeding. See, you just avoid the bladder pillar like the one that I showed, and then it will be fine. And then afterward, we're talking about the placement of the wound reflector. Where should we put it? If you're already able to perform total phenol, you will skip all of this phase. So in the anterior, we put the wound retractor behind the symphysis pubis, and then on the posterior, we just put it right behind the sacral vertebra. But to do it properly is not so easy. So as you can see, I squeeze the inner ring of the wound retractor, and then I push it in from the 6th position. From the 6 o'clock position, I push it until it reaches the sacral vertebra, and then I push the anterior side. I push the anterior side, and then with my longest finger, I push it and then position it behind the symphysis. As you can see, it's going to be like that. And then it's not so easy. Especially this part is a bit troublesome, especially for beginners. And then when we start the total phenols, it's also a problem. That's why we start the total phenols. And then afterward, we push in the second ring towards, and then we position the wound retractor firmly in the vagina. And then the next step is, you must remember that you cannot control the bowel movement. So that's why I always include gauze in my technique, because the gauze will prevent the unintentionally movement of the bowel. It will preserve the bowel from the injury. As you can see, just like this, you see, I put a thread because Karapol first doesn't put a thread, but then he losing it, and then I put in the thread because on my first 5 cases I lose the thread together and perform it with Dr. Surya, and then afterward I always put the thread so it just easily to get back. And then afterward you apply the cord. Actually I was taught by Professor Lie with the luggage cord, but we don't have it in Indonesia. And also I tried some the applied medicine, but I don't have it in Indonesia. So we are using the glove cord from Korea that's available in Indonesia, and it is very cheap. For Indonesia setting, anything cheap is good. Anything expensive, we cannot afford it. And then this is one of the tips that I took from side is already open. You see my gauze is preventing the movement of the bowel, but the air keep coming in, and then you push up, so it makes a movement like a wave. If you are afraid to penetrate, if you see the wave, you just penetrate, because there is nothing there. You will be safe. And this technique, these tips, I also use it in the total phenols. This is one of the total phenol case that I performed. This is 1.2 kilogram my mother's uterus. As you can see, I just put in the wound retractor. It was very bulging. I cannot see anything. But luckily, I'm able to push in from the posterior side. So when about to push into the anterior side, for the safety, I just follow the wave side. As you can see, this is very bulging, like a bottleneck uterus. It's quite difficult. We perform it like in 2 hours, something like that. And then, if you follow the wave and you just dissect, you coagulate and you dissect, you coagulate and you dissect until you find your entry into the abdominal cavity. See? Just push and then coagulate a bit. There, you can see inside. No harm to the bladder, no harm to the bowel. As you can see, the bulging of the fibroid is still there. That's another story. Like Professor Lie said, with big uterus, we need more time to modulate it rather than to hysterectomy. And then, if you already get into the anterior side, you just perform the hysterectomy. So usually, it's very important for the first 10 cases, you stay close to the uterus, especially if you're not familiar with the anatomical sign from the phenol point of view. So it will be better for you to go close to the uterus. I learned this from Professor Lie, Professor Su, Professor Karapol. For my first cases, I always close to the uterus. Then it will be better. So you just need to coagulate and you cut. Coagulate and cut. As you can see, if you are afraid the movement of the bowel will not move because your gauze is there. So it is very, very safe and it is very, very easy. And believe me, I was very afraid in 2015 when Professor Lie, Professor Su asked me to do it. But now, 10 years later, I say it's very easy. Also, like Professor Lie said, now it's easy. Before it's difficult. And then afterward, you go to the other lateral side. So remember, with phenols, what you see is right in front of you. You do not see everything like when you perform normal laparoscopy. What you see is right in front of you. You do not need to worry what behind this. Because in laparoscopy, if you see a lesion, you don't know what behind it. But from phenols, we already see from behind. So we do not worry to injure anything else. So what you do is just push, cut, and coagulate. If you're not familiar with an anatomical part, you just go close to the uterus. Always use the basic principle of traction and contraction when you perform a normal laparoscopy, and then it will be done. Just like that. And then, if you have a smart bipolar like the one that I use here, it will be easier. But if you do not have, one of my fellow in the Borneo still using it with the normal bipolar and scissors. It took him about 2 hours for normal case, but if we perform it with the smart bipolar, we usually finish in 45 minutes, but it's still okay. Then afterward, see, for those of you who are afraid the movement of the bowel, remember, put in the gauze. Put in the gauze. Because some of the female cluster, first they don't use the gauze, but what I learned so far from them, it will control your fear. The fear is when to start, my friend. Not when you're starting it, but when you start doing it. And then you always left the lateral part behind, doing it later. So after this, you perform hysterectomy, and there will be salving on both lateral side. This part I leave it for my fellow. So my first month fellow, if they want to learn to perform venous, this is what they do. As you can see, this is one of my fellow. Dr. Ati and Dr. Dennis, they try to perform the sehingga. You see the movement, not very smooth. You see the traction, not very smooth. You see the position of the instrument, not very smooth. But it's all in the learning curve. The more you're doing it, you are more able to perform it. See, so this is always the first part for my fellow to learn venous. And then if they're doing it smoothness, and they start doing the hysterectomy technique. Now, about landmark. Can you see where the uterus and where the hypogastric? See the one that, so it will take you some time to acknowledge this sign, but it will still very easy to do. So, please start doing it. You see this is from that case. There's a heavy adhesion with a previous myomectomy, with a previous C-section. You don't need to handle that. You just need to take out the uterus. Usually, this kind of cases with abnormal uterine bleeding with a history of myomectomy or C-section prior a couple times before. If you're doing it laparotomy, oh my God. If you're doing it laparoscopic, oh my God. This is what you need to handle. But if you're doing it phenols, just leave it there. Especially if there's no constipation of the bowel and everything, just leave it there. You don't need to perform addusolysis. You just need to take out the problem, which is abnormal uterine bleeding. Finish. Very easy. You don't need a robot to do it. You just sit. With my size, I cannot operate more standing or